So when someone is thinking, okay, when am I done with all of this? 99% of the time, what they're really asking is, when am I going to be done with symptoms? Let's say that they're having terrible hot flashes. And then when they're done with those hot flashes, they're thinking, okay, I'm done with menopause. No, you're done with hot flashes, but you are not done with menopause. So you are postmenopause until you die. You are not done with menopause until you die, even if you're not having symptoms.
Welcome to Fempower Health. This is Georgie. I am thrilled to welcome back Dr. Lauren Streicher, a leading expert in menopause and women's health. And together we're diving deep into the top 10 questions women have about perimenopause and menopause, from myths around hormone therapy to the unexpected symptoms that can catch you off guard. Dr. Streicher brings extensive knowledge as a professor, author, and podcast host to guide us through this critical discussion. So whether you're just starting to navigate perimenopause and menopause or well into the journey, this episode is packed with the information you need to make informed decisions about your health. And be sure to check out her podcast, Inside Information, the Menopause Podcast, where you listen to your podcast. Enjoy this episode. Dr. Streicher, welcome back to the Fempower Health Podcast. I'm so excited to have you because we already know each other. We've already done an interview. We've been connecting in between our two interviews. And now it is time for you to help answer the top 10 questions on perimenopause and menopause. And I will just say this round, for everyone to know, you sent me the questions. And I was also going to send you questions, but your questions were so good that we're just going to use yours. And
Well, Georgie, the reason my questions are so good is these are the
I
questions
know.
I actually get. These are the questions I get when I'm talking to women one-on-one. These are the questions when I'm in a room filled with women. And these are the questions I get on my social media. So I do have a pretty good insight into what it is that women want to know because, quite frankly, sometimes they're getting the same information again and again, the more basic stuff, but they want to do the deeper dive. So I'm so happy we're going to have this conversation and do the deeper dive.
Yes. So, I mean, you are so well known, but just in case there are like the couple people who don't know you, give us your background and then we can dive into this.
I'm a professor of obstetrics and gynecology at Northwestern University at the medical school there. So I have a very academic hat where I am teaching, I'm writing, I am lecturing at scholarly conferences to other medical professionals and publishing in journals. So that's one side of what I do. The other side of what I do is I get out there and I talk to women and I give them accurate information, whether that's live events, one-on-one, or in my books or my podcast. My podcast is Dr. Streicher's Inside Information. And the premise of this is women want good information. And if they have good information, they will make good choices. And it's so hard out there. I mean, you and I've talked about this so often. There is so much misinformation and disinformation. And navigating this space is really challenging, even for women who are smart and savvy and otherwise have no problem researching the things that are important to them. And then they get into the menosphere and it's like, what? Who do I
Yeah.
believe? Who's right? So that was my goal, was to have some place that women can go to where they are going to get accurate information. I'm not selling anything. I don't have any products. I don't have an agenda. I just want to tell women what we know and what we don't know.
Right. And I think that's how you and I have bonded because, I'm not a doctor, but I have a science background and have worked in the biopharma industry my whole career. And I feel the same. And, my own experience with the healthcare system was, hold on a second. I worked in this space my entire career. I know how to talk to doctors. I'm very confident. And it's been tough for me. And I know so many women I speak with who say the exact same thing.
Yeah.
Like there are doctors even. There was a doctor that recently posted how she even struggled, like a doctor.
Well,
So
what's
it's hard.
interesting is that I assumed when I started my podcast and wrote my books that it was really going to be non medical professionals that were going to access that information. And boy, was I wrong. I get messages all the time from physicians, top physicians, super, super bright physicians who say, I never learned this stuff. during medical
Mhm.
school and residency. And in practice, I need to know this, and I go to you for an accurate source of information. And one of the biggest compliments I've ever gotten is when I'm speaking at a medical conference, which obviously is all physicians, advanced practice nurses, higher level clinicians, and people come up to me all day long and say, I listen to your podcast. I learn from your podcast. And to me, that is the biggest compliment of all.
Was shocked too. I did this for women because I was frustrated, and I'm shocked how many clinicians listen.
Mhm.
It goes to show how much of a gap there is in med school training.
Right. But the other thing, Georgie, that it goes to show is very often women say, oh, my doctor's clueless and my doctor doesn't care and my doctor's not interested. And yes, that is sometimes the case. But in many cases, your doctor really does care. They want to help you. They just don't have the information. They have not
Yep.
been given the education. So,
No,
and they're
that's
also limited
absolutely
by
true.
time. I mean, let's be honest.
Yeah.
One of
Oh
the
yeah.
biggest challenges when you go to see your doctor, basically about 15 to 20 minutes is allotted, which includes your physical exam and includes a whole laundry list of other things. So everyone is frustrated. Women are
Yeah.
frustrated. Their healthcare professionals are frustrated. And so we're trying to close that gap. And that's why I love that we're doing this.
Yeah, me too. No, I'm excited. And I 100% agree. Both parties really need the information. So let's dive into these top 10 questions. Number one, this is such a good one. Do home menopause tests work?
The short answer is no. Do not waste your money. And now I'm going to give you the longer answer and tell you why. Basically, what these home tests do is they measure a hormone called FSH, follicle stimulating hormone, that appears in the urine. And follicle stimulating hormone goes up when estrogen goes down. Sounds good, right? Sounds like that should be helpful. But the reason it's not helpful is that perimenopause, which is the time leading into postmenopause, is when your estrogen levels are fluctuating all over the place. So the majority of women that are doing one of these home menopause tests are women who are trying to figure it out. Am I still pumping out estrogen? Am I in perimenopause or am I postmenopause? So let's say they do this urine test and it says your FSH is normal. So they think, oh, I'm not perimenopausal. Well, they're not perimenopausal because on the day they did the test, their FSH level was normal, but it's like a roller coaster. It's up and it's down and it's all over the place. So they thought the manufacturers of this test said, oh, well, we're going to get around that and we're going to give multiple tests. I think you get something like 5 tests that you're supposed to do at various intervals so that you can figure it out. But that doesn't really solve the problem because someone might go for 2 or 3 months and have normal levels and then suddenly bounce around, which is why women who are getting periods and are perimenopausal, they find that, they think that they're done with their periods and then they don't buy their tampons. And then 3 months later, they're wearing white and getting on a plane. And it's like, oh my God, there it is. Some people call them a flash period. So that's number one, why these tests are not helpful. The other reason they're not helpful is that the algorithm is based not only on the urine test, the FSH level, but also on your menstrual history. So basically you log in when you have an app that goes along with the test and it's going to ask you your menstrual history. Well, I'll tell you what the problem is with this. Let's start with the fact that 1/3 of American women do not get a menstrual period at all because they've either had a hysterectomy or maybe they've had a uterine ablation for heavy bleeding or maybe they have a progesterone IUD. So what they don't tell you in the fine print until you get home and read this test is that it won't work for you. The test is absolutely worthless. So by the time you've gotten home and you've opened up the box and you've taken out the kit and all of that, and then the first thing it's going to do is have you go to the app and say, when was your last period? And you're like, my last period was a million years ago. I don't get periods because I had a hysterectomy when I was 40. And it's like, then they say, oh, well, then you can't use this test. So there's that problem. But then the other thing is that let's say you're 55 years old and you haven't had a period for 5 years. You don't need a home pregnancy test. You're postmenopause. All you've got to do is talk to somebody. This test is not going to tell you anything that you don't already know. So the reality is that for the overwhelming majority of women, this test gives them no new information. It just doesn't. It's not like your FSH is low and then it gradually goes up. so you could see, oh, here I am, and in 2 years, I'm going to be postmenopause. It doesn't work like that. It's all over the map. So then the other obvious question is, okay, well, if home menopause tests don't work, what does work? How am I supposed to know? Well,
You
this is
read
all.
my mind. That was going to be my next question.
Well, this is awfully old school, but 90% of the time, I'm going to know by talking to someone. I mean, just having the conversation. Tell me your symptoms. If you get periods, what's been going on with your periods? How old are you? What is your medical history that might impact on when you enter perimenopause or postmenopause? Do I ever get blood tests? I do, but I don't do them routinely. And you have to, if you do get a blood test, you have to get a blood test by someone who knows how to interpret it. You know, a lot of women will go say to a family practice doctor or their internist and say, gee, I'm wondering if I'm in perimenopause. Will you check my hormones? And their clinician, wanting to be helpful, will say, sure. And then they'll test their hormone level and call them up and tell them either, oh, you're, perimenopause or postmenopause or premenopause or some kind of pause. And they just say, oh, okay. And they walk away and think that's it. When in fact, that's not the whole story. It could be that the test was done on Tuesday at 2 o'clock when your hormone levels were one level, and a week later they'd be something different. So that's, goes under the heading, and this is a theme we're going to return to again and again while we're talking here, is the difference between going to an expert in perimenopause and menopause versus someone who's trying and maybe means well, but kind of doesn't get it.
I will just say this, and I think we're probably going to get to it throughout this episode. So I just want to leave with this thought is when you're in it, the perimenopause, you may not know it or may not want to admit it. Because I find with my friends, they kind of don't want to admit it.
It's an ageism. It's ageism. And to your point, people think of menopause or perimenopause and they think of grandma in the wheelchair knitting, not a 44-year-old who looks like they're 30 and feels like
Right.
they're 20. And then all of
Right.
a sudden can't understand why they're having, little vaginal dryness or hot flashes or irregular periods or all the things that go along with perimenopause. One of the things that is very challenging, both for women and for clinicians, is what's menopause and what's midlife. And a lot of times women will have particular symptoms or something that happens to them. And we have, both extremes. People that just say, well, this is just what happens when you're in your 40s and it has nothing to do with menopause. Or the other side that says, this everything is menopause. Everything is menopause. Everything isn't menopause. Everything isn't getting older. So that can sometimes be difficult. And quite
Yeah.
frankly, sometimes it's both.
Well, I guess what I had hoped with these tests, to be honest with you, is for the women who don't want to admit it, they would have data, some data, like something that would like factually, non-emotionally
Yeah.
be able to say. So I kind of hoped you would have a slight bit of a positive review just for that
Honestly,
purpose.
I really don't,
Okay.
because even if they do have a test that shows that their FSH is elevated, number one, it elevated when someone ovulates. I'm just
Yep.
throwing that out there so they
Yep.
can be completely thrown off by that, because one of the things with perimenopause is that you do not ovulate regularly, but you do ovulate, which means that you also can get pregnant. But if that doesn't mean that you have to be having regular periods. So it
Yep.
can really confuse someone.
Yeah.
And sometimes you'll have someone who really isn't in perimenopause and they're told that. I mean, the typical scenario is the woman who, say, 37, 38, maybe wants to get pregnant, has irregular periods, is thinking, gee, am I entering perimenopause early? Because maybe she's read about that or she's concerned about that. And then she does one of these home tests and it comes back with an FSH surge and she's thinking, shit, I'm done. I'm never
Right.
going to get pregnant, when in fact she was ovulating and she should have been home having sex instead of doing this home menopause test. So just throwing that out there.
So this is why I like talking to you. We don't mess around. All right. When are most women done with menopause? Okay, just the way that question is worded, I have many thoughts, but I'm just going to let you answer.
This is an answer which is 100% of women are done with menopause when they die.
Thank you. Thank you.
Now, that was the short answer. I think this is going to be the theme: short answer, long
Yeah,
answer,
that's
because
good.
that's the short answer. The longer answer is when we think in terms of these three phases: premenopause, when you're pumping out estrogen like a 20-year-old; perimenopause, when you're on the roller coaster; and then postmenopause is when your estrogen tank is on empty, right? So when someone is thinking, okay, when am I done with all of this? 99% of the time, What they're really asking is, when am I going to be done with symptoms? And
Yep.
then when they are done with symptoms, if they're having symptoms, not everybody does, but let's say that they're having terrible hot flashes. And then when they're done with those hot flashes, they're thinking, okay, I'm done with menopause. No, you're done with hot flashes, but you are not done with
Right.
menopause. And when you think in terms of the fact that we have estrogen receptors basically everywhere in our body, our bones, our brain, our skin, our vulvas, our vaginas, you name it, they're estrogen receptors. And there are potential consequences for that lack of estrogen until the end of your life because you're never going to start making estrogen again. So
Right.
you are postmenopause until you die. You are not done with menopause until you die, even if you're not having symptoms, even if you're not having any problems.
That was what I thought you were going to say. Okay. How long can I take hormone therapy for?
Until you die. And we can always go back to the WHI study, the Women's Health Initiative study that came out, 20 years ago. And in that study, they, of course, cut it short at 5 years for a variety of reasons. One, because they saw this increase in blood clots and oral estrogen. They saw that there was a slight increase in breast cancer in certain populations. And so basically, they kind of said, well, if you're going to take hormone therapy, you should only take it for 5 years or less. There was never any scientific basis for saying that. And in fact, we have found that to be highly problematic, starting with the fact that we know that a lot of women who are having hot flashes, on average, they last 7 years, but some people it's 10 years, some people it's even longer. And we just talked about the fact that you're going to have big repercussions if you don't make any estrogen throughout your life. So, as an example, many women take estrogen because this will prevent the progression of low bone mass, osteopenia, to osteoporosis. If they stop their estrogen, they will lose that bone very rapidly. So, if that's one of the reasons that you're taking hormone therapy, you don't want to stop it. If you are taking estrogen because it's helping with your arthritis, which we also know is a benefit, and you go off your estrogen, your arthritis will get bad again. And in fact, a very good study just came out this year in 2024 that looked at 10 million women, 10 million women who were continuing their estrogen over age 65. And what they found in this very, very large population of women is that they were all doing great. They had less cardiovascular disease, they had less osteoporosis, they had less cancer than women who had stopped their estrogen. So the myth of that you should only be on your estrogen for 5 years or till age 60 or whatever end point someone has been told is not based in science, and in fact we are learning quite the opposite.
Okay. What about progesterone, though? So I've interviewed Dr. Jerry Lynn Pryor quite a
Yeah,
bit on the podcast, and I know she's a huge fan of progesterone. And, many people I've spoken with feel like it hasn't been studied
that's
enough,
correct.
that it's always been about estrogen.
Yeah.
And don't please, no one quote me on this, but I feel like I remember her saying that progesterone also had a huge role in bone health. So, what can you say about the
Yeah.
role of
So
progesterone
so this
here?
is the thing. The reason why postmenopausal women on estrogen were prescribed progesterone in the first place, because we know that if someone has a uterus, if they've not had a
Correct.
hysterectomy, and if they take estrogen alone, there is going to be an increased risk of an abnormal buildup in the lining of the uterus, which long term can either lead to precancer or cancer. So that was the rationale behind progesterone. And when you look at the synthetic progesterone that was initially prescribed, medroxyprogesterone acetate, which has the trade name Provera, that was in WHI what they found had a very, very slight increased risk of breast cancer. So then we switched to micronized progesterone.
Yep.
And micronized progesterone, the primary benefit, of course, is protecting the lining of the uterus. It also has a little side benefit as it helps women sleep. Sleep is another issue post menopause.
I just got mine, my dose increased from 100 to 200,
300, you
so
could sleep a little better, yeah.
yeah.
And but as far as progesterone's role in other organs, whether it's, bone, brain, all of that, it really hasn't been adequately studied.
Okay.
And where this comes up is women who have had a hysterectomy and are told you don't need to take progesterone. And they're wondering, well, should I take progesterone? And is there any harm in taking it? And the true answer is we do not know. We do
Okay.
not know. We don't have the data. And this is also when we talk about recurring themes, this is another recurring theme because when we talk about things like should you take estrogen for brain health or should you take it for, fill in the blank for lots of other things, and the answer is we have data that suggests that it might be helpful, but do we have the kinds of studies that really answer that question definitively, meaning a placebo controlled longitudinal study that goes on for 30, 40 years that looks at that kind of stuff. And
Right.
that's, we get into the battle of the purists, if you will, the pure scientists who say no, you cannot make these recommendations until we have those studies. And then you look at the other side, which says, well, we're not going to have those studies for a long time, if ever. And so therefore, we just have to give women the best information we have. So at this point, I don't tell women to take progesterone unless they have a uterus or unless they say it's really helping me sleep, because I just don't have enough information.
Got it. And one last, I just can't let it go. Birth control. So progestin and progesterone are different. And
Yeah,
some may say, oh, well, I just got on birth control. Can you
yeah.
clarify, like, it is
Yeah.
different?
So there's really, the nomenclature is very confusing. And in fact, I have an entire podcast episode on progesterone. And when I talk about the difference between a progestogen, a progestin, and a progesterone. And basically, what we're doing is either talking about a synthetic progesterone, which is a progestin, a progestogen, which is synthetic and natural together, and a progesterone, which is natural.
Right.
Very confusing, very confusing. So when you look at birth control pills, these are all synthetic uh, progestins. And let me just say right off the bat, just because something is synthetic does not mean it's good for you. People have this idea that if something is natural, it's good for you. We have arsenic and strychnine, totally natural, not necessarily good for you. So, and this idea that if something is synthetic, it's bad for you. You can't make that blanket statement. It's
Right.
really, you have to look at the studies. Is it harmful? Is it not harmful? So, women just have to kind of get past that because a lot of it is marketing, the idea that something is natural, something safer. So when we look at birth control pills in terms of these specific synthetic progestins, we do not know them to be harmful. They certainly do not increase the risk of cancers. And in fact, women on birth control pills have a dramatic decrease in some cancers, such as ovarian cancer and uterine cancer. Just to backtrack a little bit. So the difference between birth control pills and hormone therapy is that the purpose of a birth control pill, of course, at the end of the day, what it's FDA approved for is to prevent pregnancy. And the way that it prevents pregnancy is it gives you relatively very high doses of hormones to shut your ovaries down so that they do not ovulate. That's in a
Right.
nutshell how birth control pills work.
Right.
When we're talking hormone therapy, we are giving very, very small amounts of hormone therapy to alleviate symptoms and the repercussions of no longer making estrogen. So hormone therapy will not prevent pregnancy. Let's, if you do the flip side and say, well, why don't we give a 20-year-old hormone therapy because she will get pregnant and she won't be happy. It's not going to do anything because it's small amounts. By the same token, we don't give a woman who's clearly postmenopause hormone therapy because it's far more than she needs, and we worry about problems such as blood clots and all of that because it is a higher dose hormone. The
You mean
time,
birth control?
birth control.
Birth control.
So the
Yeah.
time when we do use birth control to really supply both estrogen and progestogen is for perimenopausal women, because we've already talked about they're on this roller coaster and they're all over the place. And if they're having symptoms, if you give them hormone therapy, they will very often break through that with their symptoms and bleeding. And the best way to control it is to put someone on an oral birth control pill. And we can
Interesting.
keep them on until about age 55. And the reason why it's age 55, we didn't just pull that out of our tush. Age 55 is when close to 99% of women have transitioned to postmenopause, so they no longer need that. And a lot of
Okay.
women get very angry when they go to their doctor and they're having perimenopausal type symptoms and they feel like they're being dismissed when the doctor says to them, I'm going to put you on a birth control pill. No, they are not being dismissed. Very often, you have to think of it as a form of hormone therapy.
What about conflicting things on estrogen causing cancer?
Okay, short answer. There is no conflicting information. Estrogen does not cause breast cancer, period. This is not controversial. This is based on excellent data, which people that know the data and understand the data all say the same thing. So it's not controversial. And where this comes from, again, when we circle back to the Women's Health Initiative, and when you looked at the subset of women that did have a small increased risk of breast cancer, and these were women who were not in the estrogen alone group. The estrogen alone group had a decrease in breast cancer. And in fact, women who were taking hormone therapy and got breast cancer had a 40% decreased risk of dying from that breast cancer. So it was actually protective. So then you say, okay, well, what about these women that did get an increased risk of breast cancer? Who are those women and why did it happen? Well, there's a couple of things. Number one is it was only the estrogen and the Provera group, which was the synthetic progesterone. And there's the idea that you do have progesterone receptors in the breast and that may have acted as fertilizer, meaning it didn't cause the breast cancer. But if there was a breast cancer that was smoldering there that would have reared its ugly head years later, it showed up sooner. And I
Got
did a
it.
podcast about this with Jim Simon, who I'm sure you know because he is amazing in terms of knowing the data and his expertise of this. And the way that he explained it is that if you look at biologically how it works with breast cancer, it's not like you get breast cancer and then 10 minutes later you have the lump that shows up on your mammogram. It takes
Right.
years from the time that cell is there. So the cell starts until it grows into an invasive breast cancer. So this idea that you have this enormous population of women that start taking hormone therapy and then 5 years later they start to see more breast cancer and they say, well, this is because of the hormone therapy. Well, biologically, most breast cancers, there are more aggressive ones, but most breast cancers take way longer than that to show up. So you've got two things going on here. You have hormone therapy that's acting as fertilizer, maybe making it show up a little bit sooner, but you also have women that are suddenly getting screened. I mean, we know that mammography is the best way to find breast cancer. And sadly, in this country, huge numbers of women are not getting screened. What happens when you enroll in a clinical trial? You are getting screened. So, of course, you're going to find breast cancers that you find early, long before you can feel them, in women who would have had a breast cancer anyway. But we've also had multiple studies since then looking at estrogen alone, and which do not show that there's an increase in breast cancer. One of the things also that's interesting is a lot of people think that an estradiol, which is plant derived, here we go back to the natural thing again, is going to be better than taking conjugated equine estrogens. And in fact, if you look at the data and the experts, a lot of the experts, the true scientists, more expert than me, say that conjugated equine estrogens are actually more breast protective than the estradiols, which is kind of counterintuitive because everyone has this idea like, oh, well, plants are always better and it's more natural. And I'll just throw out there that we're a lot closer to horses than we are to plants, and nothing could be more natural than horse urine. I'm just saying. But it also, in various studies, does show to have a more protective impact on the breast. So we have to put that myth aside. And part of the problem with it is that not only are you hearing this from your friends on the media and your manicurist, but more often than not, you're also hearing it from your doctor. And you go to your doctor, and particularly if it's someone who's not a menopause expert and completely well meaning, and you go and you say, I'd like a prescription for estrogen because my hot flashes are making me non functional. And they'll say, oh, no, 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 take some black cohosh, or I'll give you an SSRI. And, estrogen's the last resort because I don't want to increase your risk of breast cancer because your mother had breast cancer or your grandmother had breast cancer. And in fact, it should be the opposite. It should be, yes, I want to give you estrogen because not only is it going to help with your symptoms, but we have reason to believe that it's going to protect you from getting breast cancer as your mother and grandmother had. So we have to change the message out there. And this is a long, difficult slog.
Yeah, no, I know. What about those with the BRCA gene though? My understanding is like there's still a lot of they're still risk and there really needs to be shared decision making. So is it true that like blanket everyone can be on hormone therapy?
Well, let's talk about BRCA specifically, because BRCA, of course, is one of the genetic mutations which increases the risk of both breast cancer and ovarian cancer. There are other mutations; it's not the only one, and that is something that has been well studied. And in fact, there was an excellent study that looked at women with a BRCA mutation who did not have breast cancer, but they were at very high risk because of their BRCA mutation. And this was a control group. It was a big study, and they found that there was zero increased risk of breast cancer in women with the BRCA mutation. And if they did get breast cancer, there was no increased risk of them either having a recurrence or of having a worse prognosis. And I did a podcast episode with Dr. Corinne Menn about hormone therapy and breast cancer. Within the program notes, I put the links to those studies
Okay.
because a lot of women, it's one thing to hear it from me, but they have to go back to their doctor and say, and this is the study that actually looked at it, because again, this is not controversial. We know that women who have a BRCA mutation, it has been studied. We have excellent data that they can safely take hormone therapy without increasing their risk.
And I also have heard, and again, I don't want to take us off track, but even those who may choose and are still nervous, they just like really make sure they get their follow up mammograms just to like have that additional like ease.
Well, yes. I mean, I would say people should be getting their breast cancer screening anyway, whether it's a mammogram or an MRI or whatever they're doing, because so I don't put that in a different category. Every woman should be getting screened. And the reason why, I mean, there's a lot of reasons why women don't do it, but one of the reasons that you and I hear most often is, well, I had a friend who went for her mammogram and then she was diagnosed with breast cancer 6 months later. So what was the point? And the point is mammogram is screening. It's not going to pick up every breast cancer, but it's the best that we have at
Yeah,
early detection, and it's going to pick up a lot of them. And we know that if you detect it early, then you are going to have the highest rate of it not being an issue in surviving.
exactly. No, exactly. Thank you. All right, here's a really important one. I'm using vaginal estrogen, but sex still hurts. How come
Yeah.
it's not working? This is a really good one.
And this is one of the topics that I actually talk to doctors about a lot, because you have a lot of doctors who are out there and their patient comes in and she's peri or postmenopause and she says sex hurts, and they automatically prescribe a vaginal estrogen, thinking that, okay, well, she's probably has dryness because she's peri and postmenopause. And the reason why the estrogen isn't working is because maybe that's not what's causing painful sex. So that's number one, is that people have painful sex at any age and without having vaginal dryness, and it might get worse at menopause. And so they're given some vaginal estrogen, but that doesn't solve the problem. And the reason why this happens is that number one, too often women are not examined. The vulva and the vagina become a no-fly zone. And quite frankly, and again, there are exceptions. Whenever I make these sweeping generalizations about certain specialties and stuff, there's always exceptions. But the
Always.
majority of internists, the majority of family practice doctors do not routinely do a gynecologic exam. They're not looking at the vagina. They're not, if someone doesn't have a pap test, especially if they've had a hysterectomy, they're like, oh, it's like you don't have a vagina and a vulva anymore. We're not going to look down there. And so when that woman develops problems, they're given a prescription without an exam. And there are so many other things that can cause painful sex. And in fact, the medical terminology for painful sex is dyspareunia. And I published an article in the journal Menopause about 6 months ago that looked at all the causes of postmenopause dyspareunia. And I was actually invited to do that article by um, the editor of Menopause, Dr. Isaac Schiff, because I gave this lecture at Harvard, which is where Isaac Schiff is, talked about causes of painful sex that have nothing to do with vaginal dryness. And everyone was kind of blown away because they really hadn't thought about that. So he said, well, can you please write an article? So I did. It took me a year and it was 80 pages long.
Oh my
And he said,
goodness.
well, we can't publish this. I said, I know, but I just felt like I had to vomit it all out and put it all out there. And now let's start editing. So the final article is only about 12 pages long, which is still, as these articles go, very, very long. But so the point is that there's a very long list of things that can cause painful sex that have nothing to do with menopause or dryness. And one of the things at the top of the list that I will mention because it's so underdiagnosed and treatable, is something called lichen sclerosis, which is a dermatologic condition that the skin of the vulva and the opening of the vagina becomes incredibly inflamed and tender and dry and tight, and all the estrogen in the world is not going to help that. It needs to be diagnosed properly. It needs to be treated with steroids, and so that's one thing. So that's number one. That's number one, why they're using estrogen and it's not working for painful sex. Number two is that they have tight pelvic floor muscles. Because when we think in terms of being able to have pain free sex, there's really two components that you need. One is to have tissue, which is healthy and lubricates and has elasticity. And the other is those muscles that are lying underneath the tissue have to be relaxed and say, come on in, we're ready. But what happens is when someone has a history of painful sex because of dry tissue and because of lack of lubrication, those muscles are going to go into keep out mode.
Yep.
They're going to tighten up and they're going to become tense and they're going to become painful. So then what happens is that if you treat the tissue and now your vagina is great, it's lubricating, there's elasticity, it looks healthy, it looks normal, but your muscles may not know it yet. Your muscles are still in keep out mode. So you take your, brand new lubricated vagina and try and put something in it, whether it's a toy or a penis or whatever your preference is, and it's still just, it won't go. It won't go. And your vagina is not stupid, and if it's anticipating pain, those muscles are going to tighten up. And that's where pelvic floor physical therapy comes in, because these are amazing physical therapists who specialize in these specific muscles, who use a lot of different techniques to get those muscles to relax. So this is completely treatable. Completely treatable. So it's not that your estrogen isn't working. It's working just fine on your tissue. It's just not doing anything for your muscles.
Yep.
And then reason number three, why vaginal estrogen very often fails. Because you might be treating the vagina's inside, but you may not be treating the vestibule. The vestibule is the opening to the vagina, and it's the door to the vagina, and it doesn't matter how nice the room is if you can't get through the door. So very often women will be using a product in the vagina, like one of the little tablets or the inserts or a ring, and the vaginal tissue is great, but the opening to the vagina is like ring of fire. And so the vaginal estrogen is working inside, but it's not working at the opening. And of course, what we do in that case is that we also apply some estrogen cream or DHEA or something like that to the opening.
And it's it's funny when you brought up point 3, because one of my next questions, because again, I know you and I are like so like nerdy about getting the details right, and it's so hard to give like a one sentence answer because it is a longer answer.
Yeah,
But I actually was taking the tablet, the vaginal estrogen tablet,
yeah,
and I switched to the cream because
yeah,
I was still having painful sex too.
yeah,
And because of all the pelvic PTs I've interviewed and urogynecologists, I'm like all about what's going on down there. And I had a feeling it had more to do with taking the wrong type of vaginal estrogen than other
yeah.
pelvic floor issues. I switched, fine. I'm
And you're fine.
completely fine.
The other thing that's interesting about the tablet is the trade name, and I don't work for any of these companies. I always like to point this out. The trade name is Vagifem, but you can get it as a generic now. And when Vagifem first came out, it was 25 micrograms, and it actually worked pretty well. And
Okay.
then they switched to a 10 microgram pill so that they could advertise. This was marketing, not science. They wanted to advertise that this was the lowest form of vaginal estrogen, which again is fear mongering, because it's implying that if you use a higher dose, that's somehow going to be riskier, when that's
Right.
not the case. So this was 100% marketing. And when they went down to 10 micrograms, it just isn't enough for a lot of women, not to mention it's not treating the vestibule. But the workaround for all of this is that a lot of times women will say, but that cream is so messy and it's so icky and I don't want to use it because it plops out of my vagina. And the workaround is use whatever you want inside, your ring, your insert, your tablet, whatever, but then use cream around the opening, then rub it in so it won't be glopping. While you're at
Yep.
it, make sure you can put it on your urethra for your bladder symptoms and go north to your clitoris to help with orgasm. So I'm a big believer in the cream for the
Yep.
vestibule and the vulva, but inside you can use whatever you want.
Do you need both? Because I only do the cream now on the outside.
If you're fine, then you don't.
Okay.
If you
Okay.
have no bladder symptoms and if sex is pain-free, then go
Okay.
for it. That's the other thing also, a lot of women think that you have to be so careful with the dosage or use it exactly as it was prescribed. And with some things, that's very true. For example, if you're prescribed a vulvar steroid for some reason, you don't want to smear it all over the place because it can cause problems. You want to use it exactly where you need it. But with estrogen, you can play with it. See what works for you. It's not like that you're given of dosage. And quite frankly, there's a lot of wiggle room there. You can use less, you can use more. It's fine.
And I will say every time I go to the pharmacy, I do get pulled aside. And they're like, "Do you know this, this, and this, and this?" Because of the black box warning. And I'm like, "Yes, got it. I take this every month. I'm good. Can I just please pay for it?" All right. Can I start hormone therapy after 60?
The short answer is maybe. And really, what it depends on is what are your goals and what are your medical issues that might impact on that. So, this is where an expert comes in. This is something that most general doctors are not going to be comfortable with, but a menopause expert will take a look and see what it is you're trying to accomplish and what things there are in your medical history that may say yes or no. We're looking particularly at where you are in terms of cardiac risk. So that's a maybe. And vaginal estrogen anytime. That's systemic estrogen. Vaginal estrogen you can start when you're 90.
Okay. Now, just to clarify, this is starting. So if you've
Starting.
started
Correct.
earlier, it's a non-issue. It's more of when you start.
That's
Okay.
exactly right. If
Okay.
you're on it, you can continue. But if you're thinking as a new start over 60, that takes a little bit more finesse and shared decision making.
Okay. And it's making sure we go to a menopause expert on this one.
Correct.
Okay. I use hormone therapy, but I still have vaginal dryness. My doctor said I can use some vaginal estrogen, but my pharmacist said that I shouldn't. It's too much estrogen. So it's okay? Is that
Yeah,
correct?
your doctor is correct. Your pharmacist is wrong. The amount of estrogen that you're getting in a systemic estrogen to prevent hot flashes and bone issues and all of that for about 30% of women is not enough to give them the support they need in the vulva and vagina. This is very low dose hormone therapy. That's why we call it hormone therapy, not hormone replacement therapy, because it's very low dose. And it is absolutely perfectly fine to pair that with a local vaginal estrogen product. This is not controversial. Your pharmacist is responding to that black box warning.
All right. I stopped my period 7 years ago, but I still have hot flashes. Is that normal?
It is absolutely normal. We know from very good data. There's a study called the SWAN study, which has been going on for, I think, about 18 years now, that really gave us all this information because SWAN started following women before they entered perimenopause and then tracked many, many things. I think there's over 600 SWAN articles right now. We're learning so much about menopause. And one of the things that they looked at was how long hot flashes last. And what we've learned is that there is a genetic predisposition, so that some women are genetically predisposed to have hot flashes that last longer. So, on average, women have hot flashes for about 7 years. Some women, it's going to be 10 years or more. Black women tend to have more severe hot flashes that not only start earlier but last longer. And Asian women tend to be the shortest. And this is not about diet. If you take an Asian woman who's eating cheeseburgers and chips all day, she is still going to be at lower risk in terms of hot flashes. And the only other thing I'll say about this when we talk about hot flashes is a lot of people think that hot flashes are not harmful and that you should dress in layers, buy a fan, and tough it out. And we now have very good data that shows that the women who have the most severe hot flashes and the most persistent hot flashes are the women that are at highest risk for cardiovascular disease. So these are not something to be ignored. Whether you use a hormonal or a non hormonal treatment, it is really important to treat those hot flashes not just for quality of life, but for length of life.
What if like you don't have them that often?
Then you're lucky. I
Okay.
mean, no, truly, if you're a woman who's not taking hormone therapy, who doesn't have hot flashes, we know that you are at lower risk for
Okay.
cardiovascular disease. This is a risk factor. And, only about 75% of women get hot flashes. There are women who do not, and we don't know why. because
Okay.
this every 100% of women stop making estrogen, and we have a pretty good idea of the mechanism for hot flashes and what's going on in the brain. But this is multifactorial, and clearly there are things we don't know because again, 100% of women stop making estrogen, and only 75% are going to get hot flashes. And when you divide up the women who don't get hot flashes from the women that get hot flashes, they are completely different in terms of their long-term risks. So
Okay.
it's the damage that a hot flash does in terms of the inflammatory reaction, the increase in cortisol, all of that.
Okay. So I do have to close the loop on this just in case anyone is like, wait, hold on a minute. So in your earlier statement about can I start hormone therapy after age
Yeah,
60, and one of the biggest factors is cardiovascular risk.
yeah,
Now we're sitting here saying hot flashes must be treated, and one of the big risks is cardiovascular
right.
risk. So can you just help close that loop? Because
Yeah,
someone
I will
may look
close
at
that
that
loop.
and be
And
like, isn't
this
that
is
the opposite?
So to close that loop, I have to go back to the WHI for a second, because in WHI you saw an increased risk of blood clots and cardiovascular events in women who are on hormone therapy, and 70% of the women who were in WHI were over the age of 60. Why? Because they wanted to have women who were no longer having hot flashes so they would know if they were getting the real stuff or placebo. So now what we know is that women who have severe hot flashes, by the time they're 5, 6, 7 years into it, the damage is already done, so that if they start hormone therapy, it actually can make whatever plaque is building up in their blood vessels to dislodge and even increase their risk of stroke. So that's what I'm talking about when I say this is a very nuanced individual discussion, to look at your calcium scores, to look at what's going on in your blood
Okay.
vessels, to make sure it's not dangerous for you to start hormone therapy over 60.
Okay, thank you. I wanted to make sure that that was
Yeah, no,
100%
it's
clear.
it's
Thank
it's
you.
it's it's an important point to
Yeah,
clarify because it is confusing, and again, nuanced. Yeah,
yeah,
that's where it gets tricky.
exactly. I know vaginal dryness is common, but it's my dry mouth that's really making me crazy. Is that menopause related? Oh, such a good one. I love this one.
It's something that, quite frankly, I'm just learning about
Okay.
because I consider myself to be a menopause expert and to be pretty good at knowing all the symptoms and all the things that women are experiencing. And one of the wonderful things about doing this podcast is that it has given me the opportunity to talk to people who either know more than I do or know different things than I do. And I did one on menopause in the mouth, and no surprise, the mouth is loaded with estrogen receptors, as are the salivary glands, and the mouth actually has a lot in common with the vagina, a lot, when we look at the kind of tissue it is, the receptors, microbiome, all that kind of stuff. So yes, this is an issue. Now there are other things that can cause dry mouth, aging, of course, and some medications, and and a lot of women in this age group are also taking medications that can dry them out. But we do know that menopause in and of itself and the lack of estrogen is very much associated with dry mouth, which is a problem, not just because it's uncomfortable and it can cause people to have, just even speech issues, but it is also identified with long term gum disease, dental disease, and all of that. And what we don't know, if you were to say to me, because I know the next question you're going to ask is, if you take hormone therapy, is that going to help? And the answer is, I've never seen a study. I don't know that it has been studied. But just like systemic estrogen helps the vagina, I'm assuming it also helps the mouth, but I don't have the data to back that up.
Okay. Fascinating. All right. Last question. We know that there's so many more, but this is the last on our list today. My arthritis has gotten much worse since I stopped my period. Coincidence or related to menopause?
We know that there are estrogen receptors in the joints, and we know that for a lot of women, postmenopause, perimenopause is when they start to have problems such as arthritis, frozen shoulder, and all of that. They can be directly related to estrogen. And I'm old enough that I practiced when WHI came out, and when women stop their estrogen, one of the primary things that women would come and say to me is, "Oh my God, my arthritis is so bad." And I was so clueless, I didn't know. And I'd say, "Oh, that's just a coincidence. You're getting older. It has nothing to do with it." And now I know that I was wrong, that in fact, arthritis does get worse if someone stops their hormone therapy or is not on it. And I don't know if you've followed the work of Dr. Vonda Wright, but she's an orthopedic surgeon who's just coined the phrase musculoskeletal syndrome of menopause. And she just published a paper in which she specifically is looking at the impact of menopause on orthopedic issues, on joint issues, and how hormone therapy can prevent much of that. So it's an emerging field, it's an emerging area of interest, but yes, you are not imagining it. It is part of menopause.
Wow. So interesting. And I'm really glad she's doing that research. I've been seeing it a lot on Instagram too about even frozen shoulder. Well, Dr. Streicher, as always, such a pleasure to connect. I love that you are so evidence based and really want to get the truth out there. I know sometimes it's hard when social media is all about the one liners and a lot of clickbait out there in a lot of the articles that come out. And so I know some want a quick fix, but there isn't a quick fix
Yeah.
necessarily, and you have to have the shared decision making. But it sounds like hormone therapy isn't as scary as a lot of people believe, and so I think it's great to hear your perspective and answer all these questions.
And Georgie, I so appreciate you taking the time to do this, because the point that you make about there are no quick answers, I mean, that's kind of why my approach is here's the quick answer, but that's not the whole story. And the
Right,
problem is that on social media, you're not getting the whole story. And I can't tell you how often people will ask me a question or DM me and say, well, can you answer this question? And I'm not just being snarky, but just to say, no, this
right.
isn't an Instagram answer. This is a much longer answer, which is one of the reasons I write books and do podcasts. I can give that longer
There you go.
answer.
Again, I still have no idea how you do it all. I don't know if you sleep because we've gone through your list of all the great things you do, and yeah, it's quite a lot. So,
Sleep is important. That's the next topic for next time.
well, thank you so much again. I really appreciate your time.
Thank you.
And that wraps up another insightful session here on the Perimenopause and Menopause channel of the Fempower Health podcast. Before you go, I've got two quick, exciting invitations for you. First, join our vibrant community by subscribing to our newsletter. And it's not just any newsletter, it's your frontline update on groundbreaking women's health research, the latest health enhancing products, and unique discoveries you won't want to miss. All of this delivered straight to your inbox, cutting through the noise of social media algorithms. Better yet, you can pick the Perimenopause and Menopause edition or the Chronic Pelvic Pain edition, or both. Second, if you enjoy our perimenopause and menopause content, don't forget that we also have a main Fempower Health podcast feed that covers a wider range of women's health topics. Additionally, if you're interested in chronic pelvic pain, you can subscribe to that specific feed too. Find these channels on our website or wherever you listen to podcasts. And if you love today's insights, show your support by rating and reviewing our podcast. Your feedback is more than just a pat on our backs. It lights the way for others seeking guidance and community in their health journey, amplifying the voices that need to be heard. And for a deep dive into today's topics, check out the show notes and explore our website at fempower-health.com. Our site is a treasure trove of knowledge neatly categorized by topics of interest, ensuring you find exactly what you need to empower your health journey. And your voice matters to us deeply. Whether you have a question, a story to share, or feedback on our episodes, reach out directly at info@fempower-health.com. Drop us a message on social media or hit reply on any newsletter. Your insights inspire our conversations. And don't forget to follow us on social media for more updates, tips, and community interactions. We're on Facebook, Instagram, and TikTok at fempowerhealth.perry.meno. Quick note, the knowledge we share here is to embolden you in discussions with your healthcare provider. It's not medical advice. Always consult with your doctor for health decisions. And remember, the diverse perspectives of our guests reflect their individual journeys, and it's not an endorsement by Fempower Health. And here's to empowering your health journey, one episode at a time. See you on the next Perimenopause and Menopause episode of the Fempower Health podcast.